Karnataka e-web series. Today we have got two well-renowned speakers and who have got passion for teaching, and we know them personally as well, and you have seen them in most of the conferences and most of the teaching programs, and they'll never say no for teaching. That's the beauty of this two wonderful souls whom I'm talking about. We have got today Dr. MOHIT Saini and Dr. VIKRAM HIREKERUR on behalf of NNF Karnataka, from our entire NNF Karnataka office, from President, Vice President, Joint Secretary, CB members, and the entire NNF Karnataka members. We would like to give a very, very, very warm welcome to you, sir. Welcome to the web series, sir. Yes, sir. So today's session will be moderated by Dr. Dinakar, sir. So now I request Dr. Dinakar, sir, to speak a few words about MOHIT Saini, sir, and Dr. VIKRAM HIREKERUR, sir. And I request you to initiate or start the session, sir. Over to you, sir. Dinakar, sir, over to you, sir. MOHIT, sir, you can put your first slide, sir. You can start sharing. MOHIT, sir. Dinakar, sir. MOHIT, sir, you can start sharing your first slide. MOHIT, sir, are you there? Can you unmute yourself and start sharing, because your talk is going to be first. Yeah. Unmute yourself, sir. Unmute yourself. MOHIT, sir. I think Singh.
Yes, sir.
Singh?
Yes, sir.
Yeah. Just check.
MOHIT, sir. Yeah, I will call MOHIT, sir.
Yes, sir. Yes, sir. You are there.
Hello.
Yes, sir. Yes, sir. Yes, sir. You are able to hear us? You can start sharing your first slide, sir.
Hello.
Hello, Dinakar, sir. Kindly unmute. Yeah. Mohit ji, you can start putting your first slide.
Okay.
Dinakar, sir, we are unable to hear you. Okay, I think there is some network issue. No problem. So I request our Gujarat NNF President, Dr. MOHIT Saini, is a chief neonatologist and neonatal cardiologist, and he has got immense interest in neonatal cardiology and especially neonatal echo. And he is a director division of neonatology and academics, Institute of Child Health, Surat. On behalf of NNF Karnataka, we would like to give a warm welcome to you, sir. And I request you to start the session. Over to you, sir.
Thank you very much. Good evening, everyone. And I would like to thank Karnataka NNF, Dr. Prashant, Dr. Dinakar, and President Sir for inviting me and making a part of this web series, which is going on very well. And it has now been established all over India and maybe in the world, I think so. So today, in the next 30 minutes or so, we will just see, like, how to first assess shock, and then how we can, treat that clinically, and as well as how echoes can guide us to have a correct treatment for the one particular etiology of the shock. So as you know, nowadays a lot of webinars and web series has been going on. People have been following that. But my only request is whenever you are seeing a webinar and try to adapt some guidelines, be careful. If you have any doubt before logging out, please, 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 I am telling you, before logging out, please ask the questions and clear your doubts. Otherwise, you may end up in a trouble like this. So when we clinically assess the shock, what are the things which we should concentrate on? First and foremost thing is, first try to recognize the shock. It is very important to recognize the shock. Second thing is to recognize the severity of the shock. We should not directly go, what is the etiology? What is the reason behind the shock? First, you should be trained enough. You should be sensitive enough to recognize the shock. Second is you should determine that how severe it is, because it needs immediate treatment or what treatment it needs. And that we determine what is the etiology. And then you plan for the treatment. So the things are that clinically we have to do the things, we have to assess, know the vitals, and investigations nowadays do include the echo. That is very important. So see, how we determine that, what determines what finally is the cellular metabolism, that is very important. But what determines that, when people started knowing about the shock, they thought, okay, blood pressure is something we need to concentrate upon. But those are the gone days now. Then people thought this cardiac output is the main thing. What makes your makes or break that, whether whatever you are doing, how much treatment you are giving, whether it is effective or not. It depends on various things. One, how much is the afterload? Number two, what is the preload? Number third thing is the contractility. These three things go hand in hand to give you the resultant what your tissues are getting. Okay, so the first thing people thought about, number one, that this blood pressure is equal to your SVR, systemic vascular resistance, and the cardiac output. And this cardiac output will take your oxygen with the hemoglobin content in that. So they thought this cardiac output is the main thing. We should concentrate on this. So that became number two. But now more and more research and everything, the result, the physiology has been telling us that it is not the blood pressure that matters. And it is not the only cardiac output that matters. What matters, what result in our life and death is the cellular metabolism. That is the most important. That will give you the final result. So most of the treatments in shock has been concentrated on the end product, that is the cellular metabolism. How much the cell has received the oxygen and how much the bad metabolites have been drained out. So that's why whenever we talk about shock, okay, we have three things. What is the afterload? That is the amount of pressure against which the heart has to pump. What is the preload? That is how much substrate from the tissue it is coming in the heart and how much contractility the heart is having. So if suppose you are having hypovolemic shock, what happens in there? This is the tissue, this is the heart. Your contractility is good, but overall substrate, that is the liquid or the blood, that is less. So you have less preload and hence you have got less cardiac output. If you're in a cardiogenic shock, what happens? There is a pump failure. So whatever is coming from the tissues, that preload is being getting added here. It cannot be pumped in adequate amount. So you have got less cardiac output because of the failure of the pump, and most of the substrate, that is blood, is being getting collected before the heart. And if you have shock like septic shock, so it is kind of mixed shock. What is happening? There is a vasodilatation happening here. So most of the substrate is getting collected here. Your pump is failed. Therefore, your cardiac outputs are less, and hence the perfusion in your tissues is suffered. So let's talk about, now we will try to learn various etiology of the shocks with the case scenarios. So this is a baby who is born to 30-year-old primary mother with rupture of membranes 10 hours prior to the delivery. This is a male baby weighing around 2.85 kgs, cried immediately after birth. This baby is born by normal vaginal delivery. Everything was well, and the baby was discharged home on day 2nd or 3rd of life. So as usual, after 2 days of discharge, this baby came for normal checkup in your outpatient. So this baby is sitting in the outpatient. Suddenly the baby was not well. So parents complained that the baby is not feeding well. Baby is lethargic and is having less urine output. So when the baby was examined, the baby was mottled. There were poor pulses, cyanosed and gasping. I think most of the pediatricians or neonatologists who have been running practice for more than 5 to 10 years, at least they have come across these kind of scenarios at least once in their experience. It is very common, not very common, but it is not that they have never seen such kind of babies. And it happens in their outpatient departments once or twice in their experience. So when the CFT was being seen, it was being prolonged more than 5 seconds. Heart rate was 100 per minute. All pulses were poor. There was grade 2 murmur. BP was not recordable. The SpO2's pre-ductal was 69%. Post-ductally, it was not recordable. So what differentials? See, first what we did, we tried to assess this baby and we diagnosed that, okay, this is a shock. The baby is in shock. Then we try to assess what the severity of the shock. Only the third thing, then we count what may be the etiology so that we can plan our treatment. So that's why differentials are very important in these babies. So in the differentials, as you can see, like sepsis is always the first thing in the newborns. Okay. Then comes hypoglycemia and CNS metabolic. But as we see the clinical, the vitals, what we have seen, pre-ductal, post-ductal pulses, and the time of presentation. So it very much, points me that there may be a cardiac etiology in this baby. So the next thing is now we would like to know the etiology so that I can treat this baby. Okay. So this is the X-ray. X-ray is not very indicative of any particular pathology. As you can see, there is no pneumonic infiltrates much. There are only, kind of plethora is more, not much. Spaces are good. Heart is not any particular shape as we tend to read, boot shape heart or egg on end appearance or that kind of stuff. Okay. So there is not much I can make a direct diagnosis from this. But I can tell you it is not very important, that what kind of pathology it may be particular. I need to have a gross idea regarding if I want to start any treatment. Okay, so if I take this differentials A, B, C, D, I may say, see, as the clinical presentation was, it may be hypoplastic left heart syndrome, critical coarctation of aorta, left outflow obstructive lesion or right outflow obstructive lesion. And as you will see, we will be explaining that, but most of the babies, if they present on third, fourth day, okay, and they present in shock, that happens more in duct dependent lesion, systemic duct dependent lesion. Okay, the systemic flow is duct dependent. If they present with hypoxia, that is more common in right flow obstructed lesions. That is that pulmonary circulation is duct dependent. So I have to classify in a broader section. Okay, I cannot clinically or by just simple investigations, I can diagnose that it is a contraction of aorta or it is hypoplastic left heart. But I know that it is left outflow obstructive lesion because typically how the baby presented on day 4th and 5th of life. So it seems that the systemic flow, blood flow is duct dependent. So as you can see in this slide, the pulmonary blood flow lesion, if it is duct dependent, they present predominantly with cyanosis. If there is a systemic blood flow blood flow is duct dependent, they present predominantly in shock as our baby presented. So these are the lesions. If your pulmonary blood flow is duct dependent, these are the reasons. Hypoplastic right ventricle, tetralogy of left pulmonary, a lot of these things where this pulmonary blood flow is duct dependent. If your systemic blood flow is duct dependent, these are the diagnoses which can contribute to this. Critical coarct, hypoplastic left heart and all that. So, but these can be diagnosed only on the echo. But that should not stop me to wait for an echo and treat this baby. I should start the treatment, appropriate treatment as soon as I make a clinical diagnosis. Okay, so this is the echo video. So what you are seeing, it is a arch view, okay, suprasternal arch view. So what you're seeing is ascending aorta, arch of aorta and descending aorta. In this, you see in this descending aorta where this part, this descending aorta starts, arch of aorta and isthmus of the heart, what we say. You can see there is acceleration of the blood flow. That shows there is some narrowing here. And then as the sweep is being done, you can see this red jet of the blood. So that is a duct. So it is shunting from left to right. So that shows that there is narrowing of the arch. Okay, critical coarctation is there, and this is the most common site. And the systemic flow is duct dependent. So by third and fourth day, when your duct starts closing, your baby will present. And this is how this happens. This is your pulmonary artery. This is your descending aorta. And if your arch narrows, you can see the bidirectional shunting with increased acceleration in the flow of the blood through the duct. So that shows the duct was closing, and hence your baby presented clinically in shock because the systemic blood flow is duct dependent. And these are the Dopplers in the descending aorta, you can see. So when you see the Dopplers, you will see two color. One is very prominent, this blood flow, more blood volume is coming. Then this blood flow volume is decreased, but the velocity has increased. So it is around 3 to 4 meters per second. What we call is tailing of the flow. And this tailing of the flow pattern is very commonly seen in coarctation of aorta. So in this, I will just like to make your, spend some time, just one slide for to how you get the arch view. So always see, this is the baby. Okay. Always imagine a clock in front of the baby. Okay. This is 12 o'clock, 6 o'clock, 3 o'clock, and 9 o'clock. So your arch view is a high parasternal view. So this is your probe. Your probe pointer should be pointing at 12 to 1 o'clock position in the suprasternal notch. You put that probe there, okay, and this is how this is the view you will get. So this is your ascending aorta. This is your arch of aorta with 3 branches. This is your descending aorta, and this is your cross section of right pulmonary artery, RPA. So in this, as you can see, all the lumen of this ascending arch part and descending part of the aorta is very uniform. There is no constriction anywhere. As you were seeing in that previous video, there was flow acceleration at this isthmus part because of the coarctation of aorta. So this is known as the aortic arch view. So just to give you an idea, there are basic views we need to know before we assess the heart by an echo, especially in the newborns. So normally we do it in the different windows. So basic views, what we normally do is a apical view from the apical window. That is a apical 4-chamber and 5-chamber. Then we have parasternal views. Parasternal views are again, they are divided in low parasternal views, high parasternal views. Low parasternal views are two types: parasternal long axis, parasternal short axis. High parasternal views are ductal view, pulmonary artery view, pulmonary vein view, aortic arch view. Ductal view again is a high parasternal view. And then we have the subcostal views. How we do it? Okay, one, always it's easier to imagine a clock in front of the baby. This is 12 o'clock, 6 o'clock, this is 3 o'clock, and this is 9 o'clock. Okay, then we determine the windows on the chest of the baby, because that gives you a very gross idea where you are going to keep the probe. Then you do fine tuning to get the particular view. Okay, so first is the apical view. Apical view is in the around 4th or 5th intercostal space just below the nipple in the mid clavicular area. Next is parasternal views. Parasternal views are again low parasternal views and high parasternal views. These are the parasternal, high, low, and low parasternal windows. Then you have suprasternal, that is the aortic arch view, suprasternal view. And then you have the subcostal views. So those subcostal views are between the line between Xiphus sternum, point between Xiphus sternum to umbilicus, upper 1/3 and lower 2/3, where the point is, that is the window for the subcostal views. And in these windows, we have different views. So that's how you get to complete a whole echo study for the newborn. Okay, so apical 4-chamber and 5-chamber view, why I'm telling, because it is very important to grossly see the structure of the heart. Like suppose if you have this kind of baby, which is having suppose having hypoplastic left heart. Okay, so this is what normally you keep your probe in the apical window. Pointer is pointing at 2 to 3 o'clock position. Okay, and you can see this is anatomically upright, corrected. The probe orientation marker in the window echo screen is down here. In most of the other views, you will see this thing is up here, but it will always be on the left side of your screen. That is by convention. So here you can see 4 chambers: LA, LV, RA, RV, interventricular septum, interatrial septum, tricuspid valve, mitral valve, descending aorta, and these are 1, 2, and 3 are the pulmonary veins entering into your LA. If you have hypoplastic left heart, as you can see in this, so you can see this LV is totally almost not there. The dominant chamber here it is RV. This is hypoplastic left heart. So when this kind of babies, suppose even if I have not done echo, but clinically it has shown me or it has indicated me that it may be a cardiac lesion. And as the baby presented in shock, so this may be a duct dependent systemic flow. So it's always good to start with the prostaglandins without waiting for an echo. Suppose there is no cardiac lesion, then you can stop prostaglandins. Even if baby comes in hypoxia, that means the pulmonary flow is duct dependent. Even then your prostaglandins will help in that. So there is no harm in starting prostaglandins without doing an echo. So let's talk about another scenario. So that was regarding the cardiac thing. If you have any cardiac issues, cardiac anomaly. Now suppose if this is a baby, male baby, birth weight of 3.6 kg, born to gravida to para 1 mother. Born by normal vaginal delivery, cried immediately after birth, and then was discharged home. On day 3rd of life, admitted with lethargy and refusal to feed, admitted in some peripheral NICU, was started on oxygen and IV antibiotics, thinking in terms of sepsis. Then started having labor breathing, so and a lot of issues, was ventilated, and then because of persistent shock, was shifted to level 3 NICU care. Baby was already ventilated, was on very high pressures on 100% FiO2. On admission, the baby was still mottled, was in DIC, and there was bleeding at the puncture sites. Baby was very edematous, and mainly because of third spacing, was very typical in DIC with sepsis and shock. These were the admitting vitals. Heart rate 140, SpO2 in the right arm was 78% on 100% FiO2. This is the IBP. Systolic blood pressure was 32, diastolic 24, and mean of 26, which is, even though the blood pressures are not very significant, their sensitivity and specificity is very low. IBP is better than NIBP. But if you go by the blood pressures definition, this was really both systolic and diastolic, both were very low. CFT was prolonged and pulses were poor in all the 4 limbs. So now the question comes, how to manage this hemodynamically very unstable baby. So baby was given bolus, and by this time was already on dopamine, dobutamine, vasopressin, and adrenaline. Okay. Now people may say, why not NORAD and vasopressin? Vasopressin is a drug which is very less studied, but has shown a lot of significance, especially in shock in babies with PPHN. It has been very well used. Where many units now are using. There are a lot of issues with that, but NORAD, yes, much more established drug. So that controversy can be solved in lectures for inotropes. But this is actually the baby was on. Even on these 4 inotropes, the baby's blood pressure was systolic 36, diastolic 28, and mean of 30. So what next? So then, what was done? Echo. So now in most of the units, if you have the echo facility, okay, we have this guidelines and protocol in most, like in my unit, if the baby is on 2 or more inotropic support, then and the baby is not improving, we need to get an echo done for that baby, because there can be many other issues for which these inotropes are not working. So now this is the echo for that baby, the case we were discussing. So this is subcostal view. Okay. So what we are seeing is subcostal longitudinal view. What is this? This is IVC. This is the hepatic vein, and this IVC is going up and joining your RA. Can you see this IVC? So it is just collapsing, almost kissing each other. Even though the baby was so much edematous, but intravascular volume was negligible in this baby. So this baby was hypovolemic. Everything went into third spacing. Okay. So there was no intravascular. So even though the baby was in septic shock, but it was presenting as hypovolemia. So that's why none of the inotrope was working. So this is just a chart. If you assess the IVC diameter by doing an echo, this is for the term babies. It has not been validated in preterms. So as you know, the IVC has got variable diameters in inspiration and expiration. So I had maximum and minimum diameter. So this is your maximum diameter. If your maximum diameter is less than 8 millimeters, collapsibility is more than 50%. Okay, then it is hypovolemia. So this shock will be fluid responsive. If your max diameter of IVC is less than 8 millimeters, collapsibility is less than 50. So it may be lower of the normal end. You may give fluid, but this is definitely a fluid responsive. If your max diameter of IVC is more than 8 millimeters, collapsibility is less than 50%, it is around 8 or less than 8, it will is normal. But if your diameter, upper diameter is more than 8 millimeters, but there is no collapsibility, it may be your RV has failed, or if your baby is on very high mean airway pressures on invasive ventilation, either on high frequency or conventional, then your this assessment does not hold good for assessing your intravascular blood volume. So and then you should not act on this. It is faulty then. So in our baby, it was basically your issue was hypovolemia. So instead of increasing or adding on any inotropes, we started giving boluses to that baby, and that baby became better. So this is just to show how you do the IVC in subcostal view. Okay, so this is your subcostal window. From Xiphius sternum to umbilicus, upper 1/3, lower 2/3. Your pointer is pointing at 12 o'clock position. Okay, and if you sweep a bit on the right side, this is the view you will get. And as you can see on this, this pointer indication marker is on the upper side of the screen. This is your IVC joining your RA, and this is your hepatic vein. So whenever we are assessing shock, see, we discussed in one of the case that the clinical parameters pointed us this may be a cardiac thing. So without doing an echo, we started with the prostaglandin. And in this, you saw that clinically we did everything. 4 and 5 inotropes were going on, but the final etiology was clear only by doing an echo. So you can say that you cannot leave clinical, and clinical cannot be 100%. So you have to have everything together. So whenever you are doing clinical assessment, these are the few things we should be concentrating on: heart rate, CFT, pulses, urine output. CFT, pulses, urine output, I just give a mnemonic of CPU. What monitoring you do, heart rate, NIBP in sick babies is useless. If you want to have blood pressures in sick babies, it has to be IBP. And then the investigations, lactate, ABG, electrolytes are important, calcium is important. And then echo is.
Mohit sir, please unmute sir.
So echo is now something which we add on to these investigations. So let's talk about this baby. This is a preterm or term baby. Your CPU with your pulses, urine output, everything is decreased. Your IBP is decreased. Your lactate increased. Your cardiac output is increased when you do an echo. So what is showing? It may be your cardiac contractility is decreased. Your SVR, there is vasodilatation is going on. So what it represents? It represents your mixed shock, which the most common reason for that may be sepsis. So if I want to treat the shock, I need both inotrope and vasopressors, means dobutamine, epinephrine, or adrenaline in combination to treat this kind of shock. See, all my clinical investigation and echo things give me the idea that this is what the issue may be. This is the issue, and this is how I should treat this baby. And in this, when you are assessing, the one thing is preload. We talked about that in IVC case, how we assess this preload. Then we have afterload. I will be talking about that. But another main thing when we assess shock by an echo is the functions of the ventricles, both right ventricle and left ventricle. Because nowadays, whenever we talk about the blood pressures, it is not simple blood pressures, mean blood pressures. Now the shock is defined as systolic blood pressures are low. So it is systolic hypotension. Only diastolic blood pressures are low, it is diastolic, or it is mixed. So we don't talk only about mean. It is always systolic, diastolic, and mean all together. So when we talk about the ventricle functions, we always assess systolic functions, diastolic functions and combine. So whenever we do this systolic functions, we always do it for the left ventricle, right ventricle, both. There are different parameters for that. Like whenever we assess the left ventricle functions, first thing for both RV and LV, it is eyeballing. You need experience for that. We will talk about that, sure. Then comes the fraction shortening FS, and then comes the EF, ejection fraction. To know what is the effect of afterload on the contractility of the heart, this is what we use, velocity of circumferential fiber shortening. Most of the literature does not, it's not very strong regarding in newborns, but I don't know if Dr. Dinekar is there, is a fan of this because the Japanese people have been using it quite a lot. For diastolic functions, there are many advanced things which have come up in the echo in the newborn. But basic, when we do an echoes, what we see is EA ratios. And for systolic, diastolic both, we have tie index, but now we do have tissue Dopplers and speckle tracking, which is more specific and is done, but it is still under research. It's a research tool. It has not been put into the clinical tool yet. For these two slides, I would like to thank Dr. Biraj. She's a neonatologist in Anand for giving me these slides. And this is eyeballing I was talking about. So,
Mohit sir, can you unmute, sir? Yeah.
So this is for eyeballing. What we do is we do the 4-chamber view, apical 4-chamber view. So for this, you need some experience. Okay, then you come to know whether this contraction is normal or decrease or high, hypercontractility is there. Mildly reduced or poor. So that's why this is kind of loose classification. It is very subjective. As you can see in this here in this slide, you can see two hearts. They are contracting. One is this on the left side of your screen, and one is there on the right side. As you can see, this heart is contracting very well. But here you can see both these ventricles are contracting very less. The contractility is less. And this blue jet, what you're seeing is TR jet. Okay. Just by eyeballing, you can say, okay, this heart is not functioning well. This heart is functioning well. This is what is eyeballing is. So your contractility is what the heart is pumping, is a pumping of the heart. It is being seen in the apical 4-chamber views. One parameter we measure in a apical 4-chamber view is EF, ejection fraction. So that is we calculate the volume of the ventricle in systole and diastole, and then we assess that how much blood it has been pumped out. And this method is known as Simpson's method. Normal value is around 45 to 75%. For FS, fraction shortening, we do it in parasternal long axis and short axis, both low parasternal views. The normal value is 25 to 55 and is a low parasternal views when we do. And we will talk about this a bit. So the cardiac contractility indexes are FS, that is fraction shortening, EF, that is ejection fraction. And to do this, this fraction shortening, we use parasternal long axis and short axis, and we use M mode in that. And to calculate EF, we use apical 4-chamber. On adults, they use apical 2-chamber view also. And that is by calculating the volume change in systole and diastole. This is by seeing the changes in the diameter in systole and diastole.
तू वो काम कर खाली उत्ते कर नहीं है तुम्हें क्या करो नहीं है मेरा
I think so you have.
Sir, I have unmuted. Please unmute, sir.
Okay.
Yeah.
So what we see in parasternal long axis view? See, in parasternal long axis view, many some of the congenital anomalies like TGA can be ruled out, but that is by doing the sweep. So we won't go in detail of that. We will just see how to do the parasternal long axis view. So as I told, it is a low parasternal axis view. The pointer is pointing at 11 o'clock position at the nipple line. Okay. So this is we are cutting the heart in longitudinal view. So this is the view you will get. So this is your anterior wall of RV, interventricular septum, LV. This is your aorta, and this is your mitral valve. So here by doing the M mode, we calculate the fraction shortening. So this is how it is being done. So from here the line goes. This is what you will get in M mode. and these are the various things you will get. Okay, so this is your left ventricle diameter in diastole minus left ventricle diameter in systole divided by left ventricle diameter in diastole into 100. So that will give you the difference in diameter of left ventricle cavity in systole, diastole, and you calculate this Fs, which is in percent, and the normal value is around 25 to 55%. And then similarly, it can be done in parasternal short axis view. It is again a parasternal low parasternal view at the nipple line, but now the pointer which was in parasternal long axis pointing at 11 o'clock position is now being pointed at 1 o'clock position. And in this, you cut the heart in cross section, and this is the aorta you will see at the base. This view we also called as Mercedes-Benz sign. Okay, then you have to sweep your probe towards the apex. Okay, and you get mitral valve. In next view, you will get the papillary muscle view. And this papillary muscle view, we do this again M mode. The line like this will go within the center of the cavity. And again, in M mode, you will get a similar kind of view. And hence you can calculate the fraction shortening. In preterm, it is bit more or less 25 to 40. In term, it is 30 to 50%. But there are a lot of issues with this, but you can calculate very commonly. This parameter has been done. It is only less reliable if there is very high pressures on the right side and your interventricular septum is having a paradoxical movement, is bowing in your LV. Then it is not reliable. In that case, you should do EF, ejection fraction. This is what is being shown in this slide. So now how to calculate the contractility by EF, ejection fraction? That is by the Simpson method. The common view we commonly use for this method is apical 4-chamber view. And this is apical 4-chamber view. You will calculate basically this in all the machines. This program is being installed. It calculates your cavity volume by tracing the inner wall endocardium of the LV in end systole and end diastole, and basically calculate the difference between the volume of LV in systole and diastole. This is how it happens. This is in end systole, that was in end diastole. It calculates and this thing. But the most important thing is why it is not very well validated in newborns, because as you can see, the volume is the power 3. So if you make any any flaw in calculating the measurement, it will be 3 times increased. So that's why we have to be very particular about this. So this is regarding your velocity of circumference fiber shortening. Basically, the good thing about this thing, this is basically done in parasternal short axis view. The good thing about this is that it is preload independent, and it tells you whether your contractibility of the heart is low because of high SVR or your contractility of the myocardium is low because of effect of sepsis or hypoxia. But in literature, there is not much support for this parameter in newborns. Only literature which is in support of this parameter is from Japan. So still but now people have started using spectral tracking tissue Dopplers, which are much more accurate in giving you this information. So ventricular functions, as we discussed, which are very important in assessing the babies with shock, is systolic function. That is for the LV by eyeballing FS, EF. And RV functions basically by eyeballing. Then again, you can do, we will talk about the TAPSI and speckle tracking, which is very important. It tells you the function about RV. This is regarding systolic function. The diastolic functions, normally we do it by EA ratios. These are the Dopplers, which are being done through atrioventricular valves, that is tricuspid valve and mitral valve. And then systolic and diastolic functions together can be assessed by TIES index. So this is your apical 4-chamber view. Here you can just see whether structure is fine. All the 4 chambers are there. What is the volume, intraventricular volume, and then you can assess by doing the Dopplers in mitral and tricuspid valve the EA ratios. So this is what we have done the mitral valve Dopplers, doing the Dopplers the mitral valve, and you have 2 waves, E wave and A wave. E wave is basically the passive diastolic flow from aorta to ventricle, and this is flow due to the atrial contraction. So if the ratio normally in preterm is 0.6 to 0.9, term baby is 0.7 to 1. So if your E value in preterm is less than 0.6 and in terms it is less than 0.7, that it may be suggestive of diastolic dysfunction. So, and when we assess the RV functions, as I tell you, so one is just by E ratios or by eyeballing, but rest of the things we like, EF or FS, we cannot do the RV functions assessment because of the shape of the RV. RV has got two main chambers assess parameter measurements. One is in the anterior part, one in the posterior part. So that's why it is not easy to do EF and FS as we normally do in LV. So that's why people have started doing tissue Dopplers and speckle tracking in this. They are now using TAPSE. There is tricuspid annular plane systolic excursion. How you do it, in short, I will tell you. And now they do the EF kind of stuff. What we do in apical 4 chamber, we have a special view for RV, what we call as right ventricle focused apical 3 chamber view. Okay. So this is, we try to do Simpson's method in RV. That was as we do in LV, but that was not good because you see, it is one elliptical shape. It is not circular shape as LV. And then posteriorly, where this RVOT originates, much like almost 40% of the chamber is posterior. It is not anterior. So there are two planes of this RV chamber. So that's why it is not very easy to do this. So that's why we started doing having a special view for that, and what we call as RV3 chamber view. It is a kind of modified apical 4 chamber view, or you can do it in the parasternal short axis modified view. This is what we get. So there we get the chamber of RV full, and we get the inlet and this outlet RVOT, all the spaces we get in one view. And then you can do similar tracing as we do in Simpson's method. It will give you the EF in this 3 chamber view. And one is TAPSE. TAPSE is very simple. This is a apical 4 chamber view. It can be done in tissue Dopplers and normally by putting in the M mode only. Okay. So what it does in M mode, it actually calculates, this annular where it attaches to the valve, how much it has moved in systole and diastole, this distance. In preterm, the minimum should be 4 to 6 millimeters. In term, it should be 9 to 11 millimeters. In preterm, if it is less than 4, then we say that there RV dysfunction is there. In term, if it is less than 8, we say it is RV dysfunction. So this can be done in your simple machines if you don't have tissue Dopplers or speckle tracking in your machine also. And this is what is speckle tracking is. Basically what is happening, it is marking the tissues in the wall of the myocardium and it tracing them. So in this, you can even, have a very regional movement of the heart also, that which part is affected. You see, this is normal. As you can see how the color is moving. And in abnormal, you can see how slowly this color is moving and of which part. So you can even assess the heart LV in different areas, whether it is a lower part, upper part, medial part, lateral part. But still in newborns, in adults, they are using it very commonly. In newborns, it is still in the experimental and in the research tool. So now we have done an echo, but now we have to apply, we need to know that whatever we have gathered by doing an echo, how to use it for treating this baby. Just see the case of baby with sepsis. Okay. In sepsis, you may have two conditions. You may have infant with sepsis with high output. You may have infant with sepsis with low output, because in this your cardiac involvement, myocardium is also involved. So if your baby is having sepsis with high output, baby will have low blood pressure, high output, cardiac output, low systemic vascular resistance. So then I need to, which will be my first inotrope. If I put butamine in this, it will be bad. So what I have done is we have given the bolus and started dopamine. In this, your cardiac involvement is also there. Okay. Because your poor myocardial functions are there, normal or low BP, normal or high vascular resistance. So you may need something which is inodilator and augment your heart. Butamine may be your first inotrope in this. So as you can see, just by putting the knowledge what you have gathered by echo and clinically, your inotrope choice has changed in a baby with septic shock. So I'm very thankful for this slide from Dr. Suryavanshi sir. I want to acknowledge him for this slide. So that was, how we assess and how we acted. In first case, we saw that how it was cardiac case and how we assessed and Without doing an echo, we started with the treatment. Second was septic shock, and you saw how it presented. It was all septic, but it was, as you can see in the echo, it was low intravascular volume. In the sepsis, you saw both the conditions, sepsis with high output, sepsis with low output. So in the similar septic patient, our first choice of inotrope changes, whatever information we got. So now we discuss this baby. This is 28 plus 3 weeker, around 1 kg baby boy, born to 32 years old, gravida to mother with no antenatal issues. Okay, steroid last dose was given 1 day prior, which was adequately covered with steroids, no PRI, and all antenatal ultrasounds were normal. Baby was born by normal vaginal delivery, Apgar score, was having distress, was within 20 minutes.
Sir, please unmute.
So we intubated and was started on the surfactant within 20 minutes of the birth. Was on conventional ventilator. Okay, the FIO requirement from 30% decreased to 21% within 30 minutes of giving surfactant. Baby was extubated to CPAP at 48 hours. Was on caffeine, and by day 4, the baby was on high flow nasal cannula with 30% FIO2, and was baby at that time was on 2 cc's every 2 hourly of the feeds, but then started having minimum aspirates. This was the X-ray which was done. Okay, there is a streaky but good volume, streaky appearance, nothing much. Baby was stable, chest is clear, murmur 3/4/6. Pulses in all the 4 limbs are equal, not bounding. This is the heart rate, blood pressures are okay for the gestation and the age, abdomen soft. Everything else is well. Okay, but baby started with a bit of increase of FIO2 requirement and intolerance of the feed. So if you have a baby, preterm baby, whose CPUs have come, pulses are becoming bad, or lactates are increasing, IBP is decreased or maybe normal, lactate increased, but when you do an echo, your cardiac output has gone up. So what can be the thing? So it points towards that it may be a shunt, because it was typically 4th to 5th day baby, preterm, 1 kg given surfactant. So as your right-sided pressure has gone down, your PDA becomes hemodynamically significant. So in that case, instead of giving inotropes to this baby, if you assess that this is a PDA, the closure of PDA will make the baby improve instead of adding on the inotropes. So this is just how you do a ductal view. So this is a high parasternal view, ductal view. The pointer is pointing at 12 o'clock position, and position is left subclavicular area or left parasternal area in the upper second or third intercostal space. Kind of modified short axis view. What you see is this is pulmonary artery and this is descending aorta. And this is what you will see. You are seeing this red color jet, which is going from descending aorta towards the pulmonary artery. Red, if it is jet is flowing, blood flow is from left to right. If it is from right to left, it is blue. In this, you can see it's a bidirectional flow. Red and blue alternate. What is the significance of this? This is again a thing which has to be covered in the PDA lecture. But I just want to show you a kind of chart that this is how you label it, that how much this PDA is hemodynamically significant. We label it at mild, moderate, severe. We do it on the basis of PDA size, LA ratios, EA ratios, IVRTs, isovolumetry relaxation time, what is the left ventricle output, and how much the SMA and AC, the Dopplers, when we assess. So this whole chart gives you an idea that whether this PDA is hemodynamically significant, and if it is significant, how much significant it is, whether it is mild, moderate duct, or it is a very large or severe duct. Let's talk about this baby. So this is baby S. Okay, so in this slide, you can see this upper part is what we did from the cardiac point of view, and this is what we did from the respiratory point of view. So this is a term baby born to a mother, antenatal no issues, but baby was born by emergency LSCS because of fetal distress. So as soon as the baby was born, was having hypoxic, okay, and the baby had 2 or 3 arrests just after birth. So was revived by and then by giving adrenaline, and then was started on adrenaline infusion. Okay, initially this baby was started on conventional ventilator, but within the first few hours the baby was shifted on high frequency ventilator on nitric oxide. And these small little hearts, you can see these are the echoes which was done. As the baby was not maintaining, was going into repeated arrest, immediately on ventilator, this baby, we did an functional echo. It showed the heart was structurally normal, but there was a severe dysfunction of the ventricles and there was severe pulmonary hypertension. So what we did, we put this baby on high frequency study on nitric oxide. As soon as, and we added on dobutamine along with the adrenaline. Okay. But after a few hours, as you can, we did X-ray, ultrasound, and abdomen, chest, and everything was been fine. After 12 hours, after 6 to 8 hours, when we repeated, the functions were better, the pH decreased, so it responded to nitric oxide. As you can see, within 1 day, the baby was off nitric oxide, and slowly we weaned off, and was off high frequency, was conventional. By around 2 or 3 days, the baby was extubated. He improved so well. And by around day 8, the baby was discharged. So what happened, how we assessed on this thing, the first thing we assessed was it was not congenital anomaly. Then it was because of severe PPHN, we acted immediately after by putting the baby on high frequency nitric oxide, and baby responded to that well. So this is the echoes which I am trying to show. See, this is apical 4-chamber view. This is a normal contracting heart. This was her heart. Okay, you see bilateral ventricles are, dysfunction. There is a marked TR jet. So that is one of the parameter to assess the severity of pulmonary hypertension. So inotrope choice in PPHN shock. The first choice is mostly in most of the units. This is normally the most of the units they follow. Dobutamine or milrinone. Milrinone only if your diastolic blood pressure is more than 3rd percentile for the given age and gestation. The next step they will see is they will start with the low dose epinephrine or norepinephrine. Most of the units now started using epinephrine. And third choice is vasopressin. But in our unit, we have much of the experience for vasopressin in these kind of babies. So our normal is what we start is dobutamine, sildenafil. Again, your blood pressures are, diastolic blood pressures are more than 3rd percentile only then. Then the next thing we add is vasopressin. There are a lot of issues also. People, they do talk about the vasopressin and low urine output. Yes, if you have experience, then you have to titrate the vasopressin as per the blood pressures and then the urine output. Like in today only in the morning in one of the neonatal group, I saw one case discussion was going on one of the baby with the PPHN and shock and the vasopressin. There was a renal shutdown. 2 days back only we had a baby with this with total anuria for 12 hours, but baby was on high frequency nitric oxide. Slowly baby's blood pressure were improving. So the first I know baby was on adrenaline, vasopressin and dobutamine and sildenafil. So in that case, what we decided to wean off as per the respiratory things, nitric oxide and all that, but we started to wean off vasopressin first. So as soon as the baby was off vasopressin, in most of these babies, when the baby is off vasopressin, around 6 hours, they start pouring out. And then you will have an issue with hypovolemia because they pour out very, very heavily. You have to look for that also. Our baby did not pass urine for more than 12 hours, even 12 to 18 hours. Even though the creatinine was within normal range, electrolytes were fine. We gave 1 dose of Lasix because the blood pressure was maintained, and then he started pouring out. And they started pouring out with a volume of around 3.5 to 4 ml per kg per hour. And when in our unit, we start vasopressin, and next step, we go for low dose epinephrine. Oh, see, this is one baby who was referred at around more than 28 days of age, was having hemodynamically significant PDA, was being treated, but it was not been closed for ligation. And this graph, what I am showing is basically 0 hours is hours after the PDA ligation. As you can see, initially when the baby was received, these blood pressures were fine, but around 5 to 6 hours started dropping down. We added dobutamine, increased the dose of dobutamine, and as you can see in this chart at hours, the FiO2 requirements kept on increasing. Mean airway pressures to maintain SpO2 went on increasing. pH was acidotic and lactates were increasing. And as you can see, this little heart, this means an echo was done at that time. Even at 20 of dobutamine, the baby was not maintaining the blood pressures. But after doing an echo, something happened that increased the blood pressures, systolic, diastolic, and mean blood pressures, all. What happened? So this is the echo. As you can see in this is a apical 4-chamber view, and there is a collection around that. So it was not pericardial, it was a pleural effusion. How to differentiate pericardial and infusion? Again, it's talk. I will not include in that, because that is to be done in peristernal long axis, and you tend to see differentiate how whether it is pleural effusion or pericardial effusion. So this was a large pleural effusion. So what happened? We put the chest drain. It was been drained out, and the blood pressure improved. So it was a physical thing which happened after cardiac surgery. So it was not functional. It was physical collection there, which was hampering the function of the heart. So that's how it is not only cardiac specific. You should look around the cardiac, around the heart also for many things. And you should try to relieve that to relieve your shock states, shock etiologies. So this is just a table to show you that not only the echoes and not only your clinical thing will give you an idea how you treat and how to diagnose these babies with the shock. You have to go, it has to go hand in hand. Like, see, if you have normal or high blood pressures and your cardiac outputs are normal or high, you can sit on it. Many times we have done that, even though your blood pressures are showing, low, but your cardiac outputs are fine, baby is fine, lactates is okay. We haven't done anything to those babies. If your blood pressures are low, your cardiac outputs are high, it may be a PDA, especially in the preterm babies, need to treat that, or it may be a vasodilatory shock, high output shock, like in sepsis. So need to add the pressors. If you have high normal blood pressure but low cardiac output, that may be because of your high afterload. In that case, you need something which is inodilator, like milrinone or dobutamine. If you add dopamine or adrenaline in that, it will be detrimental. If you have low blood pressures, low cardiac output, that is very common, specifically in the shock babies, then you need a combination of the therapy. It is very important. So then, just by assessing this, you can reach your target, whichever target you take. Either you take by echo or by blood pressures, but you have to, your echo parameters should also improve, your clinical parameters should also improve, your baby should be clinically well. That is very important. So you see, sometimes it gives you guidelines. You try to follow them. If somebody comes, tells, no, these guidelines are not proper for this baby, you try to fight them people. But you only realize after seeing the final result. So that is very important. So in the end, I would like to thank everyone for listening to this. And yes, it is always good, even though it is unlocked, you stay home and safe. Otherwise, you may end up from here till here. Thank you.
Thank you, Mohit ji. Wonderful presentation. Dinakar sir, you are there?
Yes, sir. Yes, sir. Yes, sir.
Thank you, sir.
Oh, Mohit ji.
Sir.
Beautiful talk as usual. अरे यार आपको नहीं ऊपर चढ़ रहा हूँ, but really nice talk. Excellent, beautiful, and with the case scenarios, with actually type of shock, cardiogenic, volume, or warm shock or cold shock, beautiful. And we will go for the discussion also with that, if anything is there, if any questions are there. And we will go to the next talk. Vikram sir, how are you? Dr. Vikram?
Yeah, I'm fine, sir. How are you, sir?
Please, sir. Very fine, sir. Thank you.
Thank you so much.
Thank you, sir. Sir, over to you. And please, sir, if everybody knows who are you, for your one talk, 4,000 people have come from, you are from Maharashtra, Solapur. For your one talk, 4,000 people have attended. That I know you are master in ultrasound and echocardiography. It is your passion.
Yeah.
Please, sir, over to you, sir.
Yeah. Thank you, sir. Thank you so much. I will share my slides.
Yes, sir.
I am audible, sir?
Yes, sir. Yes, sir.
So at the outset, I would like to thank NNF Karnataka State Chapter officials for including me on this esteemed platform, especially Dr. Dinakar sir and Dr. Prashant for pursuing me to join this platform. And finally, congratulations for this excellent, outstanding series of webinars. Before I start, I would like to thank my seniors and my juniors also who helped me in achieving this skill. I would like to seek their blessings and best wishes. This would be my first words, that ultrasound should not be a substitute but a supplement to and correlated with a good physical examination. I am a pediatrician working in a tier 2 city. All cases, pictures and videos are from my personal experience. And there are limitations because I am a pediatrician. I am not a radiologist. I am not a cardiologist. Comprehensive sonography is not my aim. The aim is point of care ultrasound and emergency room application. This is the infamous animal which has become popular. I have put this slide, sorry for that. But this animal, it negotiates itself in dark because of phenomena called echolocation. It uses ultrasound waves to negotiate itself in the dark. In 1877, the piezoelectric effect was discovered by the Peary siblings. And then in 1915, after the Titanic mishap, research was commissioned for a way to find out the obstacles beneath the sea, and the hydrophone was discovered. And afterward, later on, it was applied to the humans. The plan today would be to discuss some cases of ultrasound as applied to the lung, heart, and the brain. Sir, am I audible properly? Sir, am I audible properly?
Yes, sir. Yes, sir.
Yes, sir. Yes, sir. Go ahead, sir.
Yeah. Okay. I will begin with lung ultrasound first. And you all know this wonderful person, Dr. Daniel Lichtenstein. His pioneering work paved the way for lung ultrasound. And all he did was he identified the lung artifacts. Artifacts are the structures that do not have the anatomic correlate. But he identified. But he identified them.
Sir, kindly unmute and continue reading, sir. Continue your presentation, sir.
Yes. So Dr. Daniel Lichtenstein identified these lung artifacts and labeled them as pleural line, A line, B line, and the lung sliding. And it is the study and analysis of these artifacts that defines the different pathologies. There is something called as the wave characteristics, and as the sound waves moves to different tissues, its propagation velocity changes. And you can see that in the air it is only 330 meters per second, but whereas in water, soft tissue, it is 1480 meters per second. When the waves pass through to different tissues of different characteristics, something changes happen, reverberations happen, reflections happen, and that define the ultrasound shadows, images. Now let us move on to the case. This was an operated case of esophageal atresia and tracheoesophageal fistula. The first X-ray was on the OT immediately after the surgery, and they found that there is a pneumothorax. So they adjusted the intercostal drain and then took another X-ray, and then they said that now baby is okay, you can take the babies to the NICU. And this is how the baby was in the NICU. There was reduced breath sounds on the right, and we were not really happy with this type of respiration. We persuaded the surgeons to do something, but they said, no, this is all we can do. After persistence, I talked to them, and before that I had to prove that something was abnormal. So I did the lung ultrasound. So this is on the normal side, that is left side. You can see that there is lung sliding. You can see that there are B lines. But on the right side, the lung sliding is conspicuous by its absence, and there are no B lines. And we all know that a single B line rules out pneumothorax, whereas these signs are very much suggestive of pneumothorax. So we showed the surgeons this, we said that there is something wrong, you do something. So they changed the ICD from number 16 to number 20. And now let us see what has happened. On both sides now there is beautiful lung sliding and B lines are there. So pneumothorax has disappeared. The pneumothorax which was not visualized on the X-ray, and this is the baby now after change of ICD from number 16 to number 20. And there are other signs of pneumothorax as well. The normal appearance of the lung is a seashore sign because there is difference between the chest wall and the normal lung. There is clear-cut demarcation, but in pneumothorax this demarcation is absent, and there are horizontal lines like a barcode sign or a stratosphere sign, like the layers of atmosphere that are stacked one over the other. Then another sign is the absence of lung pulse. Normally, lung pulse is transmitted to the pleura and it is seen as pulsating pleural line. This is absent in pneumothorax. Then there is something called as a lung point. Absence of lung pulse and lung point are more specific of pneumothorax. So what happens is that sometimes the air pockets are small or moderate in a grade. They do not cover the whole of the thorax. So there will be a point where the transducer lies that there is no pneumothorax underneath. It is a normal lung, and at some point there will be air. This usually happens with the expiration when the air because it is an air collects in the anti-gravity manner. The lower part of the chest, which is at a higher level than the upper part of the chest, the air pocket will accumulate there. But when inspiration, and this demarcation between the normal lung and the air pocket is the lung point. But what happens in inspiration? The thorax, it inflates and now the air pocket goes below the transducer. So part of the air pocket will be below the transducer and part of it will be away from the transducer, and this happens with phases of inspiration and expiration, and the same thing I will demonstrate in a patient. You see that there is lung sliding, then there is absent lung sliding, present and absent. So as the pneumothorax slides below the transducer, you get a absent lung sliding, and when it goes away from the transducer, you get a lung sliding. When you take a M mode, you get alternate seashore and barcode sign. So this is the lung point. Another way of defining lung point is when the lung pocket is very small, especially in the newborn, it doesn't cover the whole of the thorax. It covers only the anterior part. It doesn't cover the lateral part. So when you keep your transducer, half of the transducer will lie over the pneumothorax and half of the transducer will lie over the normal lung, and that point is the lung point. Now as in this patient. So medially we see a pneumothorax. So on the medial side we are seeing the pneumothorax. We see a barcode sign, and on the lateral part where the pneumothorax is not there, we will see a normal seashore sign. So this is another way of identifying the lung point. Then recently there was some article where we found where they showed that the mirroring of the ribs is also an important sign of pneumothorax. So this, I reviewed my slides and I found that in 2013 I had found one, but I had not identified at that time. So this is the mirroring of the ribs, which happens because the propagation velocity of the air changes from solid to air. So finally, to summarize, pneumothorax is identified by absence of lung sliding, absence of B lines, presence of stratosphere sign, absence of lung pulse, presence of lung point, and mirroring of the ribs. There is something stating that Dr. Mohit is requesting control. Prashant sir?
Yes, sir.
Prashant sir, shall I continue? There is some caption there. Stop presenting.
No.
Okay, fine. Okay, sir. Okay. So message that pneumothorax may not be seen on an AP view because the structures, when the patient is lying supine, the X-ray plate is at the bottom. So structures near the plate are better seen, whereas air is lying on the top. So pneumothorax may not be seen on the AP view. Either ultrasound or a claustral lateral view is used to diagnose a pneumothorax. Now we move on to another set of cases. Here this patient had come on day 2, but within few hours after birth, baby was in respiratory distress. But on day 2 also it was treated as TTN, but on day 2 also the patient is having respiratory distress, and this was the X-ray that we had taken, and you can see that there is increased bronchovascular markings. There are very tiny breakdown lesions all over the chest on both the sides, and the right hemidiaphragm is obscure, stating that there is some problem there, most probably a consolidation. But we cannot make out on the X-ray 100% that this is consolidation. So what we do is do our ultrasound, and we find that on the right side there is a subpleural pneumonia. There is air bronchogram. There is a dynamic air bronchogram, and on the left side as well in the subpleural area you can find that there is a consolidation identified by presence of air bronchogram which stands out against the background of a hypoechoic or a black colored lung. When we concentrated on that particular area, we can beautifully see the air bronchogram, air coming in and going out of the airways and standing out against the background of the consolidated lung. Another sign of pneumonia is a solid tissue appearance. This pneumonia can be visualized in this picture on the left hand side, and it is comparable to the liver and kidney on the right side and spleen on the left side. This is called the solid tissue appearance of the pneumothorax. One very important point is that one should identify the diaphragm, because the lung is superior to the diaphragm, and many times mistakes have been made, the spleen and the liver have been mistaken as the diagnosis of consolidation. So identification of diaphragm is very important. Pneumonias have got boundaries. They have a superficial boundary, which is usually the pleural line, and they have a deeper boundary, which is the transition between the abnormal lung and the normal lung. At times, though I have not used this very frequently, but increased vascularity is seen in cases of pneumonia. This is compared to the normal on the right side of their screen. Then this was a newborn who had respiratory distress. You can see clearly X-ray was taken, and X-ray is showing a patch on the right side, which is involving the upper zone and the middle zone. Fine. Now we label this as pneumonia and we will start the treatment. But what about the opening up of the abnormal segments? Which segment to target? That is the question. So for that, I did the ultrasound. First I did in the, and for the anterior segment of the right upper lobe, we can see that this is clear. There is pleural line is there and B lines are also there. Then I targeted the apical segment. Again, this is showing a pleural line and B lines, then there is normal lung. And what about the posterior segment of the right upper lobe? It is clearly showing a consolidated lung, air bronchogram and a solid tissue appearance. So what I did was I targeted the posterior segment of the right upper lobe only for chest physiotherapy, because it becomes very difficult to give chest physiotherapy in a newborn. 4 days later, this was on 24th of September, on 28th of the September, this is the picture. The consolidation has totally resolved, and it is said that on X-ray you may not see the resolution for many days, up to 3 weeks, but on ultrasound we are able to see the opening of the lung on 4th day itself. To summarize, pneumonia is characterized by absence of normal lung features, sonologic air bronchogram, dynamic air bronchogram, tissue-like pattern. Boundaries of pneumonias can also be identified, and the color flow pattern. 95% of pneumonias reach the periphery. Water is a good transmitter of ultrasound, and a consolidated lung is water rich. X-rays being two-dimensional and represent only 60% of the lung. This makes ultrasound a superior modality for diagnosis of pneumonia vis-a-vis the X-rays. And on top of that, they do have a therapeutic role in targeting the chest physiotherapy. Now we'll come to some cases of interstitial syndrome. Before that, for the residents, I would like to bring out the concept of interstitial syndrome. Now, interstitium is the space in between the alveoli and the capillaries. Now there is interplay between the capillary hydrostatic pressure and the osmotic hydrostatic pressure. Capillary hydrostatic pressure tries to push the fluid, whereas the osmotic pressure tries to pull the fluid into the capillaries. But normally the net flow is from outside the capillaries into the interstitium, and this is carried by the lymphatics. But lymphatics have a certain capacity. If the interstitial fluid accumulation is too great, they will not be able to drain the fluid from the interstitium, and that is the point when the fluid will start accumulating in the interstitium first, and if the accumulation is more, then it will start accumulating into the alveoli. So by ultrasound we can identify this clearly. This picture will show you, and now this is identified by increase in number of the B lines. More the B lines, more the amount of the fluid in the interstitium, and these are the multiple B lines that are present in one of the patients. And this is another patient. The B lines are now so much that they are coalescing together. In some part you can see the B lines separately, but in some part they have come so much together that you are not able to identify them clearly. Now this picture, when it is seen on the left side as well as the right side, anteriorly, posteriorly, laterally, in each and every segment of the lung, then this is defined as hyaline membrane disease. On contrary to that, in some patients, we see that all lung parts, zones will have some different picture. In this case, there is just minimal breakage of the pleural line and few B lines. Here we are seeing a subpleural pneumonia, air bronchogram. Here the air bronchogram is less. The subpleural pneumonia is very small, and here it is very tiny. So different phases of the lung, different zones of the lung on the left side, right side are showing a non-homogeneous picture, and this usually happens with meconium aspiration syndrome. Then this is the usual X-ray in a little bit older child, very characteristic of ARDS, and this is identified by multiple B lines in that area, and as well as subpleural pneumonia with a patchy distribution. Some areas of the lung will be showing these features, and some areas of the lung will be totally normal with a pleural line thickening is characteristic of ARDS. So those were some few examples of interstitial syndrome. Moving ahead, another application, a 5-month-old child comes with fever and tachypnea only during fever. Interfebrile period is normal. They had taken this X-ray somewhere else and it was labeled as a patch. Now this child was an operated case of congenital diaphragmatic hernia. But the relatives were very much worried because they were told that this patch is abnormal. When we did a lung ultrasound, what we find that on that particular zone, there is a homogeneous appearance with echogenicity, tiny echogenicities, similar to or slightly less than the liver or the spleen. And these scattered echogenicities have been defined as a Starika appearance, very classical of the thymus gland. So the anxiety is allayed immediately on doing an ultrasound. Still, the relatives were worried, so finally a CT scan was done which confirmed that it was a thymus. A 7-month-old with history of fever, respiratory distress. Antibiotics were given for 5 days. The child was admitted, but after that there was no response, so the child was transferred to our center. And what we found was on the first initial X-ray is that on the left side there is air bronchogram in the retrocardiac area, and on the left side, on the right side, there is complete opacity in the lower zone. So what is this actually? So we did the lung ultrasound. So you look where I have placed my probe in the posterior area, and this below the cephalic end of the probe is going to be the lung, and below the cephalic end will be the lung, and below the caudal end of the probe will be the liver. And in between that two, I have to see the diaphragm. This is what my aim is initially with this probe, which is a abdominal probe, a low frequency probe. With this background, I will show a video. You can see that this below the cephalic end of the probe, lung should be there, but it is not there. The lung shadow is not there. The liver is seen below the caudal end of the probe, and then deep to that the heart is pulsating. This I have clipped it, and is what I want to show you, that below the cephalic end of the probe there is some structure which is definitely not the lung. It is not showing any signs of lung, normal lung. Below the caudal end is the liver, and in between you can see that the diaphragm is moving. So what is this? So this low frequency probe is not helping me to make a diagnosis. Surely that lung is abnormal. I use a high frequency probe, I zoom it, and I see that there are multiple lobules here. This is a lobulated mass with a septa. You can see a septa also. So this was MRI was done later on, and it was found to be a neuro. So this was a mass in the right pneumothorax which was not responding to antibiotics. Ultrasound can give a clue to mass in the chest. Probe frequency is important. The high frequency probe, which sends the high frequency waves, they get attenuated as they pass through the structures. So they are useful in identifying superficial structures. Whereas the low frequency waves, they do not get attenuated as they pass, so they are good in identifying deeper structures. However, high frequency waves cannot penetrate because they don't go deeper, whereas the low frequency probes, they go deeper and they can penetrate the tissue. Resolution is better with high frequency probe, and it is less with the low frequency probe. So whenever you want a penetration, use a low frequency probe. Whenever you want a resolution, use a high frequency probe. Normally a balance should be achieved between the two. This is a case 39 weeker, appropriate for gestational age, respiratory distress after birth. There were no risk factor for early onset sepsis, no history of meconium stained amniotic fluid, was on ventilator. Surfactant was given for whiteout lungs on chest X-ray. It was referred to us at the end of the day 2 because the child was not responding. This was the X-ray. The left side is showing the left side is showing linear opacities, and the right side is showing opacity in the lower zone. Also, there is some amount of effusion which is seen on the right side. Now, this was the video. You can see that in some part, especially this lateral part, the A lines are there, but here there is no lung sliding, which shows that it is a pneumothorax. So I put a AM mode there and found that there is a pneumothorax there. Also, you can see that there is fluid in the lungs, fluid in the chest, and inside the fluid there are echogenicities. So definitely it is not a normal fluid. There is some, usually this is seen in empyema, but empyema is unknown in the newborn. Also, there are two types of segments of the lung are seen. In this part, you can see that the airways are crowding, and in this part, you see airways are there, but they are apart. So in the same film, same image, I am getting two types of segments. One is collapsed, the other is consolidated. So there is very odd picture. We took some fluid out and we found that this is reddish or pinkish colored fluid, and it is gelatinous. Mucinous fluid is there. And this was another clue that probably this was a lung cyst. Culture grew Klebsiella pneumoniae, and we treated the child accordingly. We put the ICD in this child. The child recovered very well. Scan was also done, which corroborated with the presence of hydropneumothorax as well as consolidation on the both lungs. But whether this is a congenital pneumonia or a lung cyst which has got infected is open for discussion on this STM platform. Anyway, the child became all right. This is a classical case of diaphragmatic hernia, and you can see that in the chest, in some part there is a normal lung, and some part there is a tissue-like pattern. Probably the intestine and spleen have come together, and we are not able to identify anything. So this is one picture of congenital diaphragmatic hernia. This is another case, clear-cut diaphragmatic hernia. There is shift of mediastinum as well. Now, I have put the probe in a lower part of the chest, also including the upper part of the trunk. So first I am going to see the kidney, then I will move my probe upwards, and then I will see the spleen, and then I will see the lung. This I am priming because I want you to see the video properly. Initially I am going to see the kidney. This is the kidney. I will start the video, and immediately after starting you will see the spleen. This is kidney, and spleen is coming into the picture, and now when I go up I am seeing the lung, and this is nowhere near the normal lung, nowhere near the collapsed lung also. There are no airways seen at all. When I put the probe over the lung, I find that this is replaced by a mass which has got cysts, various types of cysts. This was a congenital pulmonary airway malformation. This was going to be taken up as a case of diaphragmatic hernia, but this cautioned the surgeons. CPAM lesions are usually unilateral and involve a single lobe. Antenatal ultrasound can detect this. Isolated cystic or solid intrathoracic mass. The lesion may remain stable in size or may even regress. This was a little older child who had history of injury to the right side of the chest and the right upper arm. He consulted the doctor on the first day. He was all right, but on day 3 he came with history of fever and tachypnea, and this was the X-ray that was done, which is showing that there is a patch on the left side. So what is this now? The radiologist reported as bilateral pneumonia, but the child was hale and hearty in the PSU, not requiring oxygen at all, 98-99% saturation on room air, and moving about, eating well. How can this child have a bilateral pneumonia and is so stable? So we did a lung ultrasound, and we found that this is the picture on the right side and on the left side. So what we are seeing is below the pleura there is a hypoechoic shadow, and in that shadow are the echogenicities, that is actually the blood. So this was a coup and contre-coup injury because of lung contusion, which is identified by as alveolar interstitial syndrome and peripheral parenchymal lesion with presence of C lines and hypoechoic subpleural focal images with or without pleural line gap. A 3-year-old boy with history of cough and fever since 15 days, treated as pneumonia. There is no improvement and was referred. And what we found that in the submural region, there is a fairly well demarcated lesion with hypoechoic echogenic in nature, and in that there is very few echogenic opacities. A lung abscess was suspected. Though lung ultrasound does not have a routine role in lung abscess, but lesions at the periphery may be seen. They are usually mistaken for empyema and consolidation. Chest CT is the modality of choice. It was done in this case and lung abscess was confirmed. Now we'll coming to application in the cranial ultrasound. Now this picture, so in the sagittal view, you can see that there is an enlarged lateral ventricle. The occipital horn is larger than the frontal horn, a term defined as colpocephaly. There is elongation and caudal displacement of the fourth ventricle. The fourth ventricle is thin, elongated and not visualized. This is a batwing appearance because of the anterior and inferior pointed frontal horns. And the third ventricle is slightly enlarged and sometimes the massa intermedia fills the third ventricle. This child had a spina bifida and that is why we screened. This was a case of Arnold-Chiari type 2 malformation. Sometimes the newborns are taken up immediately for surgery, even not screening for the cranial ultrasound. But this identifies the anomaly and it cautions the relative as well as the surgeons that later on some problems might happen. Child may have some neurological deficit, and that surgery of the spina bifida is not the end of the treatment. This lesion was identified in utero. You can see here that the frontal horns are very small. There is no septum pellucidum. The septum pellucidum should be here. There is no septum pellucidum. Corpus callosum is there, but there is no septum pellucidum. The third ventricle has probably elevated and is communicating directly with the lateral ventricles. The occipital horns are dilated in the second patient. Then in this case, the sulci and gyri are radiating towards the surface like a sun ray appearance. And the fourth ventricle is slit-like and is displaced downwards. So widely spaced parallel lateral ventricles, narrow slit-like frontal horns, colpocephaly, elevated third ventricle extending between the lateral ventricles, and you can see that there is no classical corpus callosum. In the first picture you saw some corpus callosum. So this was a partial agenesis of corpus callosum. Here there is complete agenesis of corpus callosum. The longitudinal callosal fibers, they bulge into the lateral ventricle, making the medial border concave or straight, and radial arrangement of the medial sulci above the third ventricle is described as the sunburst pattern. This was again identified antenatally. You can see that there is a large cisterna magna, 11.6 centimeters. Anything more than 10 is abnormal, and there is hypoplastic midbrain, brainstem, hypoplastic brainstem, and a hypoplastic ventricle, hypoplastic cerebellum. This was identified. This was confirmed on MRI. These findings. This was a case of Dandy-Walker malformation. Enlarged fourth ventricle that connects to the Dandy-Walker cyst, large posterior fossa, hypoplastic vermis, a small brainstem, and obstructed hydrocephalus as well. There are other posterior fossa cystic lesions also, but in this case the cisterna magna is usually less than 10 mm. Megacisterna magna can be a normal variant, and posterior fossa subarachnoid cysts uncommonly can be seen, but they do not communicate with the fourth ventricle. This was a child who came at around 3 to 4 weeks of age, and you can see that there are cystic lesions in the periventricular area, the classical sign of a cystic periventricular leukomalacia, and was confirmed on MRI. Initially, PVL may be normal in first week or second week. Second week, it starts appearing as a periventricular white matter echogenicity, and by 2 to 4 weeks, cystic changes develop. So, in prematures, a late ultrasound will always identify such abnormalities. These cystis are bilateral, symmetrical. There is sometimes thinning of the corpus callosum, and MRI is the gold standard for PVL. This was one case where you can see that there are multiple echogens. The brain has become echogenic. The sulci-gyri pattern is not seen. Gray matter, white matter differentiation is not seen at all in these pictures. And you can see that there are areas of focal echogenicity which are scattered everywhere, including the deep brain nuclei. And there are hypoechoic areas as well in this picture. So this was a case of perinatal asphyxia. Diffuse cerebral edema is the diagnosis. Diffusely echogenic brain with poorly defined sulci, slit-like ventricles, abnormal gray matter, white matter differentiation, and focal abnormal echogenicity in the cerebral cortex and deeper structures. This was the patient, operated case of spina bifida, and came at third week of life with with fever, altered sensorium, lethargy, convulsions, and a bogey interfontanelle. And on putting the probe or interfontanelle, it gives a diagnosis that it was infected post-operatively, and this is now ventriculitis and meningitis. This was a preterm child who was in NSO for a very long time, received antibiotics a lot, and had a PIC line, was on TPN, and blood culture was sent, and it grew candida. And on screening of the brain, we find that there are multiple echogenicities bilaterally scattered everywhere, which was confirmed on MRI that these were infarcts actually, and this was invasive candida infection. Here I have put on the left side, that is right side of the screen, a normal brain, and the left side is the abnormal brain of the same patient. And here on the sagittal view, what we see that there are hardly any sulcal pattern as compared to the normal lung. Same thing in the coronal section. The sagittal pattern is not there. The Sylvian fissure is too wide. Sylvian fissure is there. This was the case. This was again confirmed on the high frequency probe, the linear probe with 7 to 11 frequency, that the sulcal pattern is very less in this patient, in coronal as well as the sagittal section, and this was a case of pachygyria. This was a case who had come to us with signs of bleeding. The patient had become pale and clinically was a hemorrhagic disease of the newborn, and you can see the normal picture on the right side, and on the left side you can see that the cerebellar area is completely echogenic. Normally the vermis is echogenic and the hemispheres are sonolucent, but here the vermis has become echogenic. Was confirmed. This was confirmed. The hemorrhage was confirmed on the CT scan that it was a cerebellar bleed. This child came to us with focal seizures on the left side, and on ultrasound what we found that there is a large echogenic area which is extending into the frontal lobe, parietal lobe, even in the deep brain nuclei, and infarct was diagnosed on the MRI. Ultrasound can be used for screening in the preterm brain, differential diagnosis of a neurological event. It helps us to evaluate that, and developmental age of the child age of the newborn can also be identified by seeing the appearance of the suture. Sylvian suture appears first by 24 weeks, then later on it is the calcarine suture, then the parieto-occipital suture, and finally the paracallosal sulcus, and then it finally bifurcates. This is a very interesting fact. This is a diagnostic ultrasound, the Bible amongst the radiologists, and the first author is Carol M. Rumack, and is a professor of radiology and pediatrics with special interest in neonatal sonography. Very inspiring personality. Now let us come to the final stage, that is echocardiography. In 1842, Christian Doppler first identified the Doppler effect, but 100 years later, the echocardiogram was first used to identify mitral stenosis. When ultrasound waves are transmitted to a stationary object, the reflected echoes are reflected with the same frequency. But when the object is moving, there is a shift in the frequency, and this is called the Doppler. If the object is moving towards the transducer, the reflected frequency is higher than the transmitted frequency. For example, if you are standing on a railway station and the train is coming towards you, as the train comes towards you, the sound increases, and then it moves away, the sound decreases. The same phenomena is the Doppler effect. If the object moves away from the transducer, then the transmitted frequency is lower. And these velocities are distinguished by color, and this is called the color Doppler. When the waves are coming towards the transducer, it is displayed as red in color. When they are moving away from the transducer, they are blue in color. With this background, you just see where I have put the probe position. It is at the bottom of the screen. Adult radiologists will put it at the top of the screen. So in my videos, since I was trained under an adult cardiologist, I have both types of images. Later on, I adapted to the pediatric cardiology style. So the probe is now below. I have put on the video. Just note the systole and diastole, opening and closing of the mitral and tricuspid valve. This is a normal heart. This I am showing for the concept of Doppler. You can see that blood moving from right atrium to right ventricle is red because it is moving towards the transducer. But there is some regurgitation also from right ventricle to the right atrium. Small amount of tricuspid regurgitation is there, and since that blood is moving away from the probe, it is blue in color. So in diastole, it is red in color. In the systole, it becomes blue in color because it moves away from the probe. So this is just a concept of color Doppler. It helps you in understanding my future slides. So the color Doppler helps you in noting the direction of the blood flow, the velocity and the pattern, whether it is laminar or turbulent. Because if it is turbulent, there will be a play of colors, as in the one of the across the tricuspid wall you are able to see that there is a play of color because of the turbulence. Now we go to cases. This is a child who came to us on 5th or 6th day of life in this state. The child had completely collapsed, almost gasping. The child was there. We intubated and revived the child. Now I want to do a apical 4-chamber view, but before that, just a brief quick slide on this, that the probe is placed at the apex and the ultrasound waves will cut the heart like a microtome and will slice the heart in a way that we are able to see the 4 chambers. The probe is directed towards the right shoulder. So this is what we are going to see, the 4-chambered heart. And this is the probe, and the direction of the probe is towards the pointer is towards the left. This is that view. Right atrium, right ventricle, left atrium, left ventricle. This is the pediatric cardiology view. But when we turn it upside down, it becomes the adult cardiology. So this is the normal heart, where we are able to see the right ventricle at the top of the screen, right atrium at the bottom of the screen, left ventricle at the top of the screen, and left atrium at the bottom of the screen. But right and left orientation is maintained. Now you see with that background, you see that this picture and video. So right ventricle and right atrium on the right side, right ventricle at the top of the screen, right atrium at the bottom of the screen. Left ventricle should be at the top of the screen, left atrium at the bottom of the screen. Now you see, you can just on the chat, you can write down your diagnosis. You can see that left ventricle is not there at all. So this is a hypoplastic left heart. And this child was suffering from that. When the PDA closed, this was a ductus dependent systemic circulation. When the PDA closed, the child became symptomatic. This was another case again on day 3 of life, not feeding well, cyanosis. And you can see on the X-ray that there is pulmonary oligemia. Now I want a view to diagnose this. So I am just bringing out this slide, that the orientation of the heart is the base to apex axis is like this, from the apex to the right shoulder. This is how the heart is placed in the body. And any view in that axis is a long axis view, and any view that is perpendicular to it is the short axis view. So now I am interested first in the long axis view, because I am suspecting that there is a pulmonary circulation is not good. So I want to identify the pulmonary artery in this case. So I want a long axis view. Now this is the parasternal long axis view. When the probe is placed in parasternal area, what we are going to see here is first the right ventricle. Below that is going to be the interventricular septum. Below that will be the left ventricle. The cephalic area will be the left atrium, and then the aorta. This is what is normally seen. And when I tilt the probe slightly below the sternum, that is point the beam slightly to the right side, I will be opening up the right ventricle as it enters into the pulmonary artery. This is a normal patient. So this is the right ventricle, this is the right ventricular outflow tract, and this is the pulmonary valve. This is a normal patient. With this background, I am going to show this picture to you. And the video, you can see that the right ventricular outflow tract is very small and the pulmonary valve is not opening at all. And this is the case of pulmonary atresia. Again, the atresia is leading to reduced pulmonary blood flow. The child was okay for first 3 days because the ductus was open, and when the ductus closed, the child becomes symptomatic. This was a duct dependent pulmonary circulation. A child coming at day 10 of life in shock in this state requires to be intubated. For this, I need a suprasternal view. I keep the probe in the suprasternal area, and now I am going to slice the heart from the top. And what I am going to see is the arch of aorta with its 3 vessels. Below that will going to be the pulmonary artery, and below that will be the left atrium. Now this is a normal heart, where you can see clearly that this is the arch of the aorta. And if I put the color, I will find that the ascending aorta is red and the descending aorta is blue.
Kindly unmute and continue presentation, sir.
So in the suprasternal view, I see the arch of the aorta and see this color flow pattern. So the ascending aorta is red in color because the blood is flowing towards the probe, and the descending aorta is blue in color because now the blood is flowing away from the probe. The Doppler effect that I told you initially. See in this picture what is happening. The ascending aorta is seen quite big, but descending aorta is very narrow, and you can see the constriction very well at this point. When I put a color flow here, you can see the narrowed flow. This was clear-cut a case of coarctation of aorta. Now imagine such patients unusually come at very late at night, at 11 o'clock, 12 o'clock. One patient I saw at 2 a.m. and then a havoc is created because these children are good for first 2 to 3 days. In fact, one patient I myself had seen on day 1, but they immediately take discharge after delivery. And day 3, day 4, they come at night in such a way we are not able to give them diagnosis. But when we give them diagnosis like this, they are much satisfied. Now this is again a 4-chamber view. Right ventricle, right atrium on the right side, left ventricle, left atrium on the left side. Now what we are seeing, the right ventricle and right atrium are very small. The mitral valve is opening and closing, but the tricuspid valve is not opening and closing. This is tricuspid atresia. Again a patient who comes with cyanosis in first few days of life. This patient, again a apical 4-chamber view. You can write down your diagnosis on the chat if you are able to know answer. See this part of the interventricular septum. See that the septal attachment of the tricuspid valve and the septal attachment to the mitral valve are very far apart. Normally this should be 8 mm per meter square of the body surface area. This is atrialization of the ventricle. This is a Epstein's anomaly, which is detected by simple apical 4-chamber view. This is another patient who came with cyanosis and shock, and you can see that all 4 chambers are communicating. This was a case of common AV canal defect. Now this picture I want you to see with little bit more attention, because this is an apical 4-chamber view, RV on the right side, LV on the left side. But as I am going to move the probe, you will first see that some vessel arises from the left ventricle, which should be the aorta. The vessel that arises from the right ventricle should be the pulmonary artery. How to identify between the two? The one which branches is the pulmonary artery. That much you remember. So as I move the probe, a vessel will be seen from the ventricle. So here you can see from the left ventricle gradually a vessel will arise, and this vessel is branching. The vessel that is arising from the left ventricle is branching. So this is a pulmonary artery. And as I move the probe still further anteriorly, I can see that this vessel which is arising from the right ventricle is not branching at all. This is transposition of the great vessels. In this picture you can see the RV and the LV apical. This is a parasternal long axis view, and both are communicating to a single vessel. And there is a VSD. So this is a case of truncus arteriosus. A simple apical, the simple parasternal long axis view identified this. Now this is a 3 videos of a same patient, and 3 different things I am going to show you. First picture is the apical 4-chamber view. You can see clearly that there is a VSD, a communication between the RV and LV. The second one is a parasternal long axis view. You can see again here that the VSD is there and the aorta is overriding the septum. It is communicating to both RV and LV. So there is overriding of the aorta, and this is the parasternal long axis view, which is for the pulmonary artery. You can see that hardly there is any RVOT and there is no pulmonary valve at all. It is not opening at all. Severe pulmonary stenosis. This is a case of tetralogy of Fallot. An 8-year-old boy with a diagnosed case of perivemerance VSD, fever since 2 months and signs of cardiac failure. Now in this case, I am taking a parasternal short axis view perpendicular to the long axis view, and I am interested in seeing the view at the basal level, where I will be able to see the right atrium, the left atrium, the right ventricular outflow tract, and the pulmonary artery. This is a normal patient, LA, RA, RV, and then this is a circle and sausage appearance of the pulmonary artery. Now see this, what is happening here? A piece of tissue is coming in and going out of the right ventricular outflow tract, and this was a vegetation. That was the reason for the child becoming not all right in spite of high level of antibiotics. A 2-month-old with cough and breathlessness was a preterm NSU graduate, came with respiratory distress. This is the apical 4-chamber view, appears normal, but around the heart you can see that there is fluid. This was a pericardial effusion, but is not affecting the function of the heart, systolic as well as the diastolic. A 7-month-old girl with bronchiolitis fails to improve for 2 days, deteriorates. An echo is done, and you can see that the heart is just a small structure floating in the fluid. This is pericardial tamponade, and fluid was removed immediately, and the child became absolutely all right after the procedure. Another case, 2.5-month-old boy with LRTI had tachycardia and gallop, and the echo of apical 4-chamber view was there. And this, few of you must have seen this case. You can write your diagnosis on the chat. You can see that the muscle is totally abnormal. There is infiltration of the muscle, the interventricular septum, the right ventricle, as well as the left ventricle. So this is a Pompey's disease. In one of the cases, which was referred to me by Dr. Mahesh Kore from Kolhapur, had a similar appearance, and we did enzyme assay for that, and it shows acid glucosidase deficiency as well as lysosomal total as well as lysosomal acid glucosidase deficiency. This was a Pompey's disease. Once you see this, you will always be able to identify Pompey's in the rest of your life. A 4-month-old girl was previously healthy, feeding difficulties since 1 day, and comes in shock. This is the state. This catastrophe happened within a few hours, and when you see the IVC, you see that the IVC is dilated, not collapsing very well. There is pleural effusion on both sides. And now I want to see the cardiac contractility. I want you to see that how to eyeball actually with the mind does not, what the mind does not know, the eyes do not see. So the mind should know first what you want to see on the image. So here I have put this picture from a standard echocardiography book, which shows that the cardiac fibers are arranged in 3 layers: the longitudinal layer, circumferential layer, and the radial plane. The longitudinal plane, radial plane, and the circumferential plane. And you have to identify the contractility of the muscle fibers in all these 3 planes. So the first is the apical 4-chamber view, which identifies in the longitudinal plane. And this you can see the heart, but what you see here is the annular excursion of the right of the side and on the left side. So tricuspid valve and the mitral valve, they are hardly moving towards the apex. Their movement towards the apex is called annular excursion. Better the annular excursion, better the cardiac contractility. Now in the radial plane, you can see that the interventricular septum and the posterior wall, they are not coming together at all. They should come and nearly kiss each other, but this is not happening. So again, this is a problem with the radial fibers. Also you can see that the anterior leaflet of the mitral valve is not opening properly. Normally it opens so well that it goes and touches the interventricular septum. So this is a problem with the radial plane, and here in the circumferential plane you can see that this interventricular septum, which is a concave towards the left side, is hardly moving at all. This was a case of dilated cardiomyopathy. And this interventricular motion is very important because sometimes it can become paradoxical, as in this case because of the pressure overload of the right heart, as in severe pulmonary hypertension. Finally, I would like to demonstrate how pulmonary hypertension is recorded, and for that I would like to tell you what is the pulse wave Doppler. In pulse wave Doppler, short intermittent bursts of ultrasound waves are transmitted. So pulse wave transmits and receives signals at particular intervals from a specific distance. So it identifies problems with only specific distance, and higher frequency shifts or great velocity or higher velocities are not identified by pulse wave Doppler. Whereas in continuous wave Doppler, the ultrasound waves are transmitted and received continuously at the same time, and the reflected signals all along the beam are analyzed, and higher frequency shifts can be easily seen with color wave Doppler. When a spectral Doppler is used, we can measure the velocity, as in this case. So this is a 4-chamber view. You can see that there is a blue colored flow from the right ventricle to the right atrium. So this is a tricuspid regurgitation. And when we measure the velocity, we put the spectral Doppler and we measure the velocity. So this velocity is coming at 84.6 centimeters per second. Now by the formula 4V square, it is converted into the pressure. So this is actually the pressure gradient between the RV and RA. So how to do this actually? So first take a apical 4-chamber view, then put the color, identify the TR jet, then put your spectral Doppler and take a tracing. Once you have taken a tracing, try to take the best velocity or the best peak, and then you put your cursor at the tip of the peak and you will be able to get the velocity and the pressure gradient. This is the video. I first took the apical 4-chamber view, then I put the color, I identified the tricuspid regurgitation jet, I put the spectral Doppler, I take the best velocity, freeze it, take the best velocity. At times you have to take 3 and then get average of the 3. So this is the pressure gradient that I am getting, which is 51. This pressure gradient is RV pressure minus the RA pressure. But we want the RV pressure, which is same as the pulmonary artery systolic pressure. The RA pressure is either taken as 5, 10, 20 or more than that, depending on the IVC. If the IVC is normally collapsing, then take RA pressure as 5. If IVC is dilated but slightly collapsing, then take it as 10. But if it is distended and not collapsing at all, take it 20 or more. So here I have taken it as 10, and now pulmonary artery systolic pressure is coming as 61. So 61 is the pulmonary artery systolic pressure, definitely high because it is normally it is just 25. Now this assumes that there is no obstruction to the right ventricular outflow tract. That means there is no pulmonary stenosis or atresia. This is the only assumption which is taken for calculation of pulmonary artery systolic pressure. And finally, this was some odd case. A 3-year-old girl with Kami's history of pain in the right tibia, and she had an injury. So on the normal side, in longitudinal as well as transverse we have taken, but on the abnormal side, what we see that there is a soft tissue appearance. There is a soft tissue appearance. There is elevation of the periosteum, and below the periosteum there is some echogenicity. So these 3 signs, the soft tissue, increase in the soft tissue appearance, the periosteal elevation, presence of a debris in the periosteal region, is a telltale sign of osteomyelitis. So this was osteomyelitis which was diagnosed on day 3. I referred to an orthopedician who was very much surprised that it was diagnosed. He took a MRI and immediately operated the child. The child went away with no bone deficit later on. And finally, the cortical erosion comes. But even before cortical erosion, we had identified the osteomyelitis. So friends, these were the few cases. There are certain limitations, definitely. The cost problem is there. Once you buy the machine, the maintenance problem is there and the training problem is there. But as doctors, we all know how to surpass these problems. The cost of the machine is equivalent to a standard car nowadays. The car value depreciates, but the ultrasound value and the knowledge will never depreciate. It will increase over the years. Now the problem of training. Training has to be given some time and patience. The study was done. This was a correlation graph between the ultrasound findings of the same patient in a beginner and an experienced person, and they found that there was hardly a deviation after proper training, which means that with some training and perseverance, this problem can be overcome as well. With all these, friends, you will definitely have your problems and obstacles, but you have to surpass them bravely and carry on the show. To conclude, this is an old modality with new application. It helps in evaluation of newborn with respiratory distress. It helps us in diagnosing intracranial abnormalities. It helps in evaluation of newborn with cyanosis, cardiac failure and shock at odd hours at night when there is no one to help you, not even a cardiologist. It helps to guide the chest physiotherapy. It helps you to guide the procedures. But the most important thing I found that it increases the comfort level of the intensivist, especially in tier 2 and tier 3 cities where there is no access or limited access to specialties. Finally, I would again reiterate that ultrasound should not be a substitute, but a supplement to and correlated with a good physical examination. Thank you for very patiently listening, and thanks NNF Karnataka State Chapter.
Thank you very much, sir. Nicu sir, wonderful presentation.
Thank you, sir.
I'm very thrilled with the way you presented. Nicu sir,
Yes, I am listening, sir.
Yes, yes.
Yes, sir, I am listening.
Dr. Mohit. Dr. Mohit ji.
Sir. Yes, yes, sir. Yes, sir.
Yes. Vikram and Mohit today really century. Excellent. Vikram HIREKERUR sir, you have told your real experience and real cases, everything you have told. And as usual, our opening.
Sir, kindly unmute, sir. Nicu sir, kindly unmute yourself.
Can I ask you some more questions, please? Because people have asked me if both speakers are ready.
Yes, sir.
Yes, sir. Okay. Number one, IVC diameter for term baby, preterm baby, or early term is what you showed in your slide. It will apply for everybody or what? Dr. Mohit ji.
Sir, in the slide, because the validated diameter is only for term babies till now. In preterm babies, the max diameter, like we assume to be 6 millimeters, but it has not been validated. So the validated diameter is still for the term babies. For ELBWs and preterm, there is no validated diameter. But normally we take 6 millimeters at the upper end. But babies less than 800 grammars, still we don't know the exact value for that. 6 is for babies more than 800 grams till 33 weeks. More than that, we take 8.
So, what is the conclusion? Because there are 8 people have asked this question.
So
What is the conclusion mean?
So anything
Yes.
which is the table which I have shown is for the term babies. So for the term babies, the upper limit of the IVC is to be taken at 8 millimeters. For babies weighing around 1 to 1.5 kgs, it is 6 millimeters. But we don't have any specific validated diameter for babies less than 1 kg.
Yeah. Sir, SVC flow, is there any value in preterm babies? Mohit.
Yes. So there is a lot of literature about SVC also. So because why the SVC flow is considered, SVC's cardiac output is considered better than left ventricle output, especially in babies with hemodynamic significant PDA. But a lot of literature has been there, and people does act on SVC flows. But now, because the exact size of SVC cannot be measured very correctly, so the reliability of SVC flow has gone down. So whenever we calculate the cardiac outputs, we do for right ventricle, we do for left ventricle and SVC, and we combine all the three and make an inference. So only SVC flow, we don't take it now as very significant.
Yes. Okay. Sir, when to use vasopressin? You told one baby had a renal shutdown. You people used in PPHN. Can you elaborate?
So like we have published 2 or 3 papers, and we did animal studies also. And what we found was that vasopressin in physiological doses is pulmonary vasodilator and systemic vasoconstrictor. So that's why it is a good drug to be used in babies with PPHN in shock. So we started using it, but there are 2 or 3 things which are bad about vasopressin. One, it is not a very good studied drug. We don't know exactly what will be the outcome in the preterm and in term babies. So normally we use it in term babies with PPHN in shock just to take the effect that it acts as a pulmonary vasodilator. So it does not increase your pulmonary hypertension as the NORAD and adrenaline does. And it is vasoconstrictor, but it also decreases your urine output. So you have to titrate your vasopressin drug and you should not be going more than 0.0005 dosage. Otherwise, there will be a total renal shutdown. So if you have a renal shutdown, you should once you have achieved your blood pressures target, you should start weaning off vasopressin very quickly. Most of the babies, they come out of this vasopressor effect of decreased urine output within 4 to 6 hours after stopping the vasopressin. So that's why, like, I will not, if you don't have any experience, then I will not advise people use this in most of the babies, especially in preterms. In term, PPHN babies, they can use, but they should have some experience regarding this. But never go more than 0.0005 dosage, international units per kg per minute.
Okay. Sir, can I use vasopressin peripherally?
No,
Mohit.
because no, vasopressin, if you use peripherally and there is extra extravasation, it will cause gangrene of the local part, local skin and all that. So it has to be used only with the central line.
Okay. Some more questions are there. Please, Ji, Mohit Ji, please wait.
Anjali,
So
yes, sir.
now we will take one question to, there are other 4 to 5 questions to sir. Vikram, are you ready, sir?
Yes, yes.
Yes, sir. Sir, you told foramen magnum more than 10 millimeter you should consider to dandy walker. Is it correct, sir?
Hello. Yeah, sir, what I told is up to 10 millimeters, it can be a normal variant. More than 10 millimeters, it should be taken as abnormal and evaluated whether it is dandy walker or whether it is something else. Because there are differential diagnoses of posterior fossa lesions. So more than 10 millimeters,
Yeah.
be careful and do an MRI scan.
Yes, sir. So number 1, sir, you showed one beautiful slide. About Klebsiella.
Yes,
Klebsiella.
Pneumonia.
Sir, what you type searching? Klebsiella you showed. You showed in your slide one syringe with gelatin material,
Yes,
and
sir.
one video, sir, not video of lung with air bronchogram collapse.
Yes, sir.
How often, sir, Klebsiella? So that means it is a pneumonic effusion with empyema, or what it is, sir?
Yeah, that is why I showed you at the end of that case that it is open for discussion amongst you specialists, sir. Because what happens is, what I saw this image, I thought that it is an empyema. But empyema I have never seen in newborn, especially day 2 or day 3 of life. I don't know about your experience, but I have never seen an empyema. And I thought that after seeing the video that it is an empyema. But when I aspirated it, it was a very sticky gelatinous appearance. So one of the our senior pediatricians say that probably this was a cyst which was there in fetal life. It was missed, and probably that has now ruptured and has got infected. Remember that this patient was a full-term child, 39-weeker, was on ventilator, was given surfactant. So there is a possibility that this could be infected. But these are the findings that we got, and a Klebsiella pneumoniae is something that we cannot neglect as a commensal on the culture. And I have myself taken this after proper painting and draping.
Yeah, sir. And in this case, you told proper antibiotics, baby went home. But
Yes,
you showed gelatin in a gelatin
gelatinous
material in a syringe.
Yes, sir. So that was
like that material you told.
Yes, so that
without
was
video laryngoscope, baby improved, sir.
Yes, yes, sir. ICD, much of the fluid I had aspirated when I had put the needle for a diagnostic tab. So much of the fluid I had already aspirated because I was already inside by doing thoracentesis. So our pediatric surgeon came and he put a ICD. We are not having VATs in our city right now. So that is why we have to go for an ICD. With this patient,
sir.
Yeah. So this patient, VATs would have been an ideal choice.
Yeah, VATs.
Yes.
Sir, one more question for you, sir. Sir, you showed one image with the pneumothorax with one size of ICDT. Later, you placed 20 gauge ICD. What was the necessary to place so big? It would have been placed to multiple ICDTs would have been better. smaller size in a neonate.
Yeah. So
Why
again,
you placed 20 size? It is very big, sir.
yeah, it is big size. So we actually asked the surgeon to do something. I was not saying that I do it, but I wanted him to do something because seeing the X-ray, he said everything is all right. But seeing the patient, I see that the patient has got a distress. So probably to make the job easy, he just removed it and put a 20G ICD. Probably his view was that probably the holes in the 16 number were getting blocked probably, and that is why we are not able to aspirate the whole air. But immediately on putting, the patient became absolutely all right. So that was his inference with all this case.
Yeah. One comment has come. It is a good comment, not comment. It is an appreciation to Vikram, sir. It is like this. You showed all the slides, practical, brain and heart, and including congenital heart disease. It was excellent. Very good. It is all practical, you told, and you confessed you are pediatrician and not radiologist, not cardiologist, but you are doing beautiful echo. Sir, hats off to you. It is a comment to you, sir.
Thank you, sir.
And,
Thank you.
it is a comment from people, sir. And so can I take Mohit, sir? Are you ready, please? Yes, boss. How can I diagnose neonate is having warm shock or cold shock in echo?
So, okay. So first thing is nowadays this warm shock and cold shock terminology is an obsolete. We don't now use the terminology that is a warm shock or cold shock. Now recently we always talk about whether it is a systolic shock, diastolic shock, or whether both the components of the shock are blood pressures are affected. So that's why we always tend to assess whether there is a diastolic dysfunction, systolic dysfunction of the heart, and what is regarding the afterload and preload. Okay, if I don't go into the higher parameters or advanced parameters of the echo, what we do is if you have invasive blood pressure, okay, if your blood pressures are low, especially your diastolic blood pressures are low, then systolic, okay, there is a wide gap in the systolic and diastolic blood pressures, and then you have high cardiac output, more than normal, okay, and clinically, sometimes we see bounding pulses or something like that. But if you have high cardiac output, but your invasive blood pressures, especially the diastolic component, is low, okay, and your lactates are high, your metabolic acidosis is there. So that counts to be the high cardiac output failure. And that typically, historically, we used to call it a warm shock. And then when your cardiac is affected, your cardiac outputs are low, your blood pressures are low, and all other parameters, urine output is low, lactates are high. We typically used to, and pulses become weak. We typically used to call it cold shock. But now these terminologies is no longer used.
Okay, I think so. One more question to Mohit. I think so. Yes. This is same. Sir, how should I decide other than the first day preterm baby? Because I clamped the umbilical cord, so I use dobutamine. But otherwise, how to decide I should use vasodilator or vasoconstrictor?
Okay, so if you have, especially this question comes, in babies with ELBW, baby is less than 28 weeker and less than 1 kg. What happens in these babies is, as soon as you have clamped the cord, so your LV, which is already is your myocardium is very weak in ELBW babies, and previously in utero it is exposed to placenta, which is a low resistance circulation. So as soon as you clamp the cord, suddenly your LV is exposed to your systemic vascular resistance of the baby, which is higher than your placental resistance, and your myocardium is already low, weak. So it is exposed to that, and then your initially your right-sided pressures are physiologically high, okay, and then your shunting from the PDA from left to right is less, but around 3 to 4 days of life, after 24 to 48 hours, they started falling. Your shunting increases, so there is another volume overload on the left side. So your weak LV is now exposed to higher volume and higher pressures, and therefore it started giving away. Okay, so if you get baby with low blood pressures during this period, when you think that there is no sepsis and baby's blood pressures are coming down, it may be because of your high SVR, physiologically high SVR and weakening myocardium. So then dobutamine is the drug. If you have a sepsis setting, okay, there is a prolonged rupture of membranes and other indices that shows you that this may be septic. Okay, then you need something that you need to cover the myocardium enhancement and your vasculature, which may be dilated to increase. So then you can choose dopamine. And then in fourth day of life, if non-septic baby, your diastolic blood pressures goes more down with bounding pulses and all other features of systemic hypoperfusion because of hemodynamic significant PDA, then you have to treat the baby with the PDA. So it has to be at what time, what is happening, and you have to rule out the other things.
Okay, Mohit ji, can I add a few things here if
Yes.
you don't mind?
Yes, please. Yes, please.
Yes. This question is actually from Varanasi.
Okay.
Dear friend, it is simple what Dr. Mohit. Number one. Is in, you know, the normal cardiac output. I'm talking about either if it is going more than 350, 300 to 350, you should have a eye on that. 300, some people do tell 280, but we take 300 to 350 is a caution level. More than 350, anything is a higher cardiac output. As it is increasing, you should be worried, provided babies also having some symptoms of shock. If it is less than 280 and going down less than 250, you should have one eye. If it is definitely going less than 200 to 170, it is more dangerous. What I am telling is correct. 170 to 300 is normal, or 200 to 300. Which one, Mohit ji? In a neonate.
Yeah, especially
Cardiac
in ELBWs and preterm babies, we take 130 to 310 normally. And in term babies, yes, it is around 250 to 320.
Okay. So suppose if the cardiac output is increases, if there is no PDA, then if the baby is having some septic shock symptoms or signs, then I do use ionotrope with vasoconstrictor like dopamine. This is my experience. Very clear, because I take 170, but 250, if it is going, I'll have a cautious. Definitely less than 200, I'll start, but the books will tell it is 170. More than 350, definitely I give dopamine. If it is less than that, then I will see what could be the reason. So I told you dopamine when I will start, when cardiac output is raised and baby is symptomatic. So when I will start vasodilator. Dilator, I will start if the cardiac output, like I don't do neonate any ejection fraction. So dear friends, colleagues, please remember how I remembered in my life, because ejection fraction, everything is skewed, problem might come. How I remembered, sorry if anybody is there, I am not talking any unparliamentary word. So remember, neonate won't have ejaculation. So ejection fraction should not be used in neonate. That is the way to remember. Because slang language, if you will use, I think so people do remember for a long time. So fractional shortening, better to use in a neonate because it is not cubed. Okay, one. Fractional shortening. Okay, if it is less, number one, and BP shows normal. BP shows normal. Then IVC is dilated. So I think volume is normal, cardiac output is less, then ejection, fractional shortening is less. Then I do, because very easy to do, posterior wall thickness. That is called, why I am telling always end systolic wall stress. I think so Mohit was telling. Really, I request everybody, including Vikram, ji aap bhi kar lo. It is very easy, sir. So 1.35 into 1.35 into just take a mean arterial pressure. That is enough. Into end systolic diastole, or what is it? Volume. During the diastole, there is full diastole D and S. During the during the diastole, this thing end systolic and LVIDS you take divided by 4H. H means HES means posterior wall thickness during the end systole. If you will do it, 4H bracket 1 into H divided by ES/DS once again. If it is less than, see, remember one thing, whenever FS or ejection fraction is low, means if it is coming low, MCF will rise. It is MCF and both are vice versa. Ejection fraction or FS. If it is low, MCF will increase. If it is high, MCF will decrease. VCF. Okay. The same thing ECWS, end systolic wall stress, is going. It is, if it is high, it is dangerous. So always keep it 40, 35 to 45. If it is more than 45, and dobutamine people or everybody is using dobutamine, try to use some minimal dose of vasodilator. So it will be helpful, because I have tried for more than till now 11 to 12 patients. My all babies have done very well with severe sepsis and the problems. That's what I want to tell you here, how to use ionotropes. Dr. Mohit ji, one more question for you.
Yes, sir.
Are you ready, sir? Sir, you told in your slides, better to take a cardiac shock. How to diagnose cardiac shock? How to diagnose it is due to the cardiac shock?
So the thing is, one is the look for the contractility, and contractility we have discussed by eyeballing, by FS, okay, and there are different methods. But now the cardiogenic shock is something which can be because of per se myocardium is getting weak, or it is because of afterload is high. Okay, for that your what you have just explained, one component is that which people use. It is just to rule out whether it is a myocardium which is weak or afterload is high. Or nowadays we use speckle tracking and tissue Dopplers to know the strain pattern. So if that thing shows, yeah, one is your FS is low, so your cardiogenic shock is there. Then the question comes whether this cardiogenic shock where your myocardium is weak because of per se myocardium is not contracting properly, maybe because of hypoxia, which is very commonly seen in this kind of stuff. Condition comes in baby with hypoxia, whether because of hypoxia or whether it is kind of compensatory mechanism by the body to maintain the blood pressure by increasing your systemic vascular resistance. So your cardiac is getting weak because of high SVR. So then your VCSF FC, like you know what you have just explained in detail. So that gives you the idea that whether it is because of high afterload or whether it is your weakened myocardium, or the speckle tracking also gives you this thing. So when your cardiac has failed, this is because of your cardiogenic shock. So it may be because of hypoxia, your myocardium has become weak, or it may be because of sepsis, myocardium has become weak, or it may be some imbalance of metabolism. That is giving the example of, or maybe in the newborns, it may be because of L kappa or something like some anatomical disorders. But it is very rare to have L kappa present in first 2 to 3 months of life. But that shows because of these things, that is your cardiogenic shock.
Yes, sir. Mohit, last question is there. I'll ask you before that, Vikram, last question. Sir, you told in your slide, microgyra or polygyra or without gyra. Sir, is it easy to diagnose in ultrasound?
Sir, I couldn't understand. Your voice was breaking. My net is for your.
Okay. Sorry, my net.
Sir,
Sir, microgyria or polygyria, microgyria. Is it easy, sir, to diagnose?
No, it is not at all easy. MRI is the modality of choice for that. But in that particular patient had a small hair compromise. We were suspecting some abnormality. That is the reason we could identify in that.
Yes,
And
sir.
it's very gross. Very gross.
Yeah. Thank you, sir. And one last question. Dr. Mohit ji. Yeah,
sir.
Please. It is for you. Sir, in your experience, you are the master. What is this? Kya likha hai? What is this? You are master in echocardiography and you are neonatologist. Sir, in birth asphyxia case, if we know that it is a severe birth asphyxia, we know that cardia is compromised. Sir, which is the first line of ionotropes? I am using in my unit dopamine and epinephrine lower dose. Is what I am doing is correct or wrong? What is your experience?
So in birth asphyxia, there are 2 or 3 things we should be very careful. One is there will be hypoxia. So your myocardium will be involved. So you should not be using something which increases vasopressor effect and less inotropic effect. And it also increases your pulmonary hypertension, and that is also a problem in birth asphyxia. So in babies, if your diastolic blood pressure is not very low, not less than 3rd percentile for the gestation and age, dobutamine is the drug to start in babies with the birth asphyxia and not the dopamine.
I think so. He understood. Sir, can he start the low dose of epinephrine? He is asking.
Yeah, low dose of adrenaline. Now a lot of literature is in favor of low dose adrenaline. So we also can use low dose adrenaline because low dose adrenaline again has got now pulmonary vasodilator effect and is a good augmenting trope for the heart.
Yeah. So yes, I think so. Everybody.
Can I ask one
sir, boliye sir. Yes sir. Sir, पूछ लीजिए, please.
Can we assess hemodynamic changes caused by the anemia or polycythemia by ultrasonography?
Vikram sir. Dr. Vikram.
Yeah, we can definitely do that because it will definitely compromise the hemodynamics. So whether it is causing decrease in cardiac contractility, whether it is reducing the cardiac output, it is putting strain to the myocardium. Yes, we can do that. But I am personally not doing it. So maybe somebody can answer.
Yes, sir. Is there any legal issue involved with the pediatrician or child specialist keeping an ultrasonography machine?
Sir, once again, repeat the question.
Is there any legal issue involved with the pediatricians are keeping a ultrasonography machine?
Yes, definitely there is. Yes, I will answer that. So definitely there is legal issue. Legal point number 1 is whether you can have the machine in your hospital. That is number 1. Unless you have a certification or registration by the PCPNDT, a vendor will show you the machine also. They will not come for demo also. So you must have first a PCPNDT registration. That is number 1. Number 2 is whether you can do it or not. So for that you need to have training. When I got the training in ultrasound, at that time the rule was that the person who is doing an ultrasound should have a degree, MBBS degree. Either he should be I think it was an obstetrician, or he should be a physician or a pediatrician. So these words were there in that document, and he should have a 6 months of experience. The question is where he should have the experience. That was not mentioned before when I took the training. But after that, I think after 2014, a law has come where the place of training has been defined, and this place of training is usually a medical college. So now, if you want, and there are many medical colleges who are offering such training for 6 months. So now, if you want to get the training, you have to go to a medical college and you have to spend 6 months and get that training. Otherwise, there will be definitely legal issues.
Thank you, sir.
So, any questions? Mohit ji, namaste from NNF Karnataka chapter from the heart. Thank you for accepting. Sir, Vikram sir, thank you. Thank you, ji, Vikram ji, thank you. You people are, I am telling from my heart, Mahan hai, legends. Arey yaar, thank you. Mohit ji, Vikram ji, both from NNF Karnataka chapter. Thanks for accepting.
Thank you so much, sir. Thank you so much.
Thank you. Yes, sir. Thank you, one and all. And thank you for the participation and wonderful presentation by our legendary speakers. Thank you very much. Kotrashi sir, our NNF president.
Hello, sir.
Few words.
Sir.
Yes,
Thank
sir.
you, one and all, for especially for VIKRAM and his wonderful presentation on ultrasound. When the tension is arisen, something should be come out from the disease. So, he has wonderfully presented on the. Thank you, VIKRAM, once again.
Thank you, sir. Thank you so much.
Thank you. Have a great evening. Thank you. Bye.
Yes, sir.